welcome. This is a quality rounds. It's a little bit different from many of the quality rounds that you'll have heard in the past, which often take on a morbidity and mortality framework. We're going to talk a little bit about quality of what we do and the way that we get or don't get feedback on our performance. And I'm going to get some feedback from you on things that you would like and talk to you a little bit about what's out there. With us is Dr. Davey Cheng, who's the only person in a lab coat, so he's easy to pick out. Dr. Cheng is a professor and chair of the Department of Anesthesiology and Perioperative Medicine, and I asked him to come and speak to us towards the end of what I'm going to talk about, a little bit about what's going on in his department on physician performance feedback, because it's an initiative that is growing some momentum. And I want to be clear that I'm not here wearing a college hat. I'm not here talking about physician performance in terms of trying to determine whether or not you are competent. I'm here to talk about physician performance feedback so that we can grow as clinicians and improve our performance. So I just want to be clear about that because most of you know that I work for the college as well. So my hope is that by the end of this session you'll be able to outline ways in which performance can be assessed. Reflect on how you would like to be assessed. So if someone is going to be able to provide feedback on your performance, what would you like them to do? What would you like them to look at? And maybe you can think or know a little bit more about some current initiatives in physician assessment. So this is Dr. Grant Stiver. And Dr. Stiver is an infectious disease specialist in Vancouver. I think he's a professor emeritus now, which probably means that he's retired. And in 1986, I was going to my fourth year of medical school, and Expo 86 was going on in Vancouver, and so I did an elective there. And I did an elective in eMERGE, and I did a one-month elective in infectious diseases, and Dr. Stiver was my consultant. And at the 2-week mark, he sat me down for my midterm evaluation and said this. He said, "You're average." And I just sort of blankly stared at him, and I said, "Average?" Because I, like probably all of you, had never received an evaluation saying that I was average. I mean, nobody's average, right? So I looked at him and I said, well, what do you mean? And what he said to me was, you need to start acting like a doctor. So he explained that what I was doing and what I did very well was I went around to the wards, I saw patients in eMERGE, I collected information from them, I did physicals, I chased down lab data and stuff from the micro lab. And I would bring that to the residents and to the fellows and him, but I wasn't really acting like a doctor. I was just gathering information. And he said, you need to start making that transition from being a medical student to being a doctor, because you're only a year away from that. And it was probably, looking back, one of the most valuable pieces of feedback I'd ever received. And it made me think, there's more that I can do in order to improve what I'm doing, because I'd just been going along doing my medical student thing. So I went off for the next couple of weeks and tried really hard and got my interim evaluation. He said, well, you're still average. But so anyway, I just dream of average now, so that was good. So what I might want to ask all of you, just to get some feedback from you, is, first of all, when you were a trainee, so that's residents currently or staff when you were a trainee, does anyone have any particularly memorable feedback that they had? If it was feedback that was given in a bad way, you might not want to share the name of who gave it to you, but if it was feedback that you found that was particularly helpful, does anyone have any experiences that they could share? Yeah, Laura?
I was a junior resident on my medicine rotation. I received a letter after my rotation just thanking me for service, and they recognizing that the census was well above numbers and that despite those challenges I was able to, perform under those conditions or something like that. And I was very surprised to receive a letter like that after the fact. That maybe not be as much of an evaluation, but.
So it was commenting on your performance, though. The assumption is that you did well on a busy service and they were thanking you for that. Great, thanks. Anyone else? Lauren?
It was my last week as an M3, and I was just about to start my electives, and a staff member told me that I should read all of the chapters of the Cardinal Presentations in Rosen's before I start. So this was like 20 chapters that I'd never heard of, and all I could think of was, oh my God, I don't know anything. He's telling me to read 20 chapters, and I start fourth year in a week, and I have to impress people? So that scared me stiff, but I didn't really realize what they were really telling me is this would be useful. Not that I don't know anything and I need to read 22 chapters in a week.
Okay. Bert?
One of the most The pieces of feedback I got was from one of our staff. It was on a Sunday morning, and he turned to me, and there was a neurological thing that I didn't know, and his feedback was, "I'm surprised you don't know this. You need to know this. Go home and come back tomorrow and know this." And it was blunt, and it was to the point, and it wasn't sugarcoated, and that's the feedback I need. And that was the most helpful, because since then I read a heck of a lot more, and that really was a kick in the butt that I needed.
I think I'm often asked by house staff, and I'm impressed by it, when they ask me, how am I doing? What can I do to do better? So now I want to ask the staff. I want to ask the staff about your life as a clinician since you finished your residency. And I want to know if any of you have any feedback that you received. And I'm not talking about the email from a colleague that says, "Do you remember that patient?" Or I'm not talking about letters of complaint, whatnot. I'm talking about feedback that you've received on your clinical performance. We're not talking about academic stuff, your clinical performance. Does anyone have anything that they can share about the feedback that they've received on their clinical performance?
We don't get any feedback like that.
Okay.
We've never received any feedback like that. I've complained about that for years, that, I've been here 13 years and I've never once had any kind of performance appraisal. I have no idea. The only way I can think to do it is that I wish that all my misses from my, the PACs, the chest x-rays, people that got sent home, that we would find out about those. I've always said we find out about the very bad cases, like you said, more of an M&M fashion, but on a day-to-day basis, you have no idea how you're doing. None.
Okay. And that's the response that I expected, and that's what I want to talk about. Oh, Gary?
Bill, the only type of feedback I think many of the faculty get is when I get a complaint, or one of my site chiefs get a complaint, and then we ask them to come to the office to have a discussion about it. I feel like the principal reprimanding them, and that's not often the case, but then they get feedback about what potentially was a negative outcome. Because, we get the odd complimentary letter. We got one the other day. I passed it on to the staff member saying they did an outstanding job, their communication skills, and from the patient's mind, they saved their life. But the other one is often I wouldn't say a robust, nice type of feedback, because you're dealing with somebody's perception of a complaint, whether it's a medical care complaint, an interpersonal complaint. So the process that we have for feeding back, I think, is very limited, because it's often precipitated by crisis or the thought of a crisis.
So the system that we have is a reactive one. It's not a proactive one. Dave?
Bill, when we had the 3 separate departments, Joe's was pretty good when Dave Taylor was head, because it was smaller. So when you started there, he would sit down regularly with you, get feedback from the charge nurses, the other docs, and he was very good at sort of guiding you through. So that was probably the most valuable stuff I received, but I think the smaller environment made it easier too.
Okay, sounds like he was well ahead of his time. Greg?
We had a system in Saudi. It was kind of an American-based system that had a points-based evaluative package that was gone over on an annual basis. Your clinical performance feedback was based on a QI M&M system that fed back to you on 48-hour returns, deaths, x-ray misses, etc. And at the end of every fiscal year, you'd sit down with your chief, and there was probably about a 6 or 8 page form that had to be filled out, and tick boxes as well as comments. And based on your score, your salary was actually affected. So if you went above average, your salary would go up. If you were below average, your salary would go down within a certain increment.
All right. So thank you for all of that. So it's nice to know that there are systems that do exist, and we're going to talk about that and talk about what's possible. So what I want to do is to talk a little bit about why we should do performance assessment of physicians, provide feedback. I want to find out what you would like, so how you would like for someone to take a look at you. We'll talk about the possibilities, a little bit about what's being done currently, and that's where Dr. Cheng is going to be able to help us out. And then I want to end up by thinking about what we can do from a grassroots level, what we can do in order to develop and formalize a system that can help us to do better at what we do. So this is an analogy I often use in giving talks on feedback, and I like to use it because it's a talk about golf. A lot of doctors like to golf. I'm not sure why, but a lot do. And many golfers will take lessons, and they do lessons to improve their swings, the mechanics of their swings. And why do they do that? They do that because they either want to hit the ball farther, or they want to hit the ball straighter or with more accuracy, and ultimately they want to do that in order to lower their scores. And so the same argument can be made for us in that what we ultimately want to be able to do is, I would suggest, is 2 main things. One is to improve patient outcomes, and the other is to improve the efficiency with which we work in our system. Okay, so the use of medical investigations, those sorts of things. So in order to do that, we need to have information about the various components of the things that we do, how we take a history, how we communicate, how we do a physical exam, which investigations we order, what we know. So there are a lot of different things that we have to work on in order to affect our ability to change what we do at the other end. So why should we do it in medicine? We do it in golf. Why should we do it in medicine? And there's a couple of studies that I wanted to share with you about this. This is one from Academic Medicine from 2011 that was a systematic review that was looking specifically at the effect of patient feedback. So if patients provide feedback to physicians on their care, does that change anything? And they only found 15 studies. And I think we need to highlight that this stuff is not well studied. There's a huge opportunity out there for us if we want to get involved in this sort of thing. All of them demonstrated that docs learned something from getting feedback from patients. Of the 7 studies that looked at performance, so actually physically looked at what the doc is doing in their department or in their clinic or in their OR, 4 of them showed some improvement. So I thought that's not too bad. Another study, which is a little bit more compelling, was from this year from the Canadian Journal of Neurological Sciences, which was looking at a team that was providing stroke care. And what they did was they wanted to improve their door-to-needle time for stroke patients. And so what they did was they provided feedback to team members on their performance in every individual patient that they saw and they thrombolyzed. And they went over with them what could have been done to improve their door-to-needle time. And what you'll see is between 2010 and 2011, their door-to-needle time dropped from 76 to 49 minutes. That's a pretty significant drop, and you'll see that by the number of zeros in front of that 5 in the p-value. So providing feedback to individuals on a team was able to improve the outcome of a specific time indicator. Now, whether or not that had an outcome on patients was beyond this study, but you could extract from that potentially that could decrease the risk of bleeding and improve the reperfusion rate and improve outcome and function. And then finally, another study from an NICU, which looked at error rates in opiate prescribing. The most common error would be the dosage in an NICU. And what they did was provided computerized feedback to team members who had prescribed an opiate and made a prescribing error. Before this study started, there was an error approximately every 4 days, 3.94 days. After they provided feedback to the team in a computerized and directed way, the number of days between errors jumped to almost 23 days. So from 4 days to 23 days, that's a significant drop in error simply by providing feedback on their performance. So it's a pretty powerful way of getting people to change things to affect a positive outcome. Does anyone know who this is? Atul Gawande. Right. So Atul Gawande is a general surgeon and a writer. Many of you might have read some of his stuff. He's an endocrine surgeon in Boston, and he wrote an essay in October of 2011 that was published in the New Yorker. A lot of his work is in the New Yorker. And what he was talking about was coaching. And he noticed that early on in his career, he followed his complication rate, because in the American system in particular, much like what Greg was describing, they collect a lot of data, and they'll feed back that data to individuals so they know where they are with respect to their complication rates. And what he found was in the first 8 years of his practice, his complication rate continuously dropped and dropped and dropped and dropped. It actually dropped below the national average. He was quite proud of himself, and then it plateaued. And when it plateaued, he started thinking, well, why did it plateau? And it reminded himself of another time in his life when something plateaued, and that was when he was younger and played tennis. So he played tennis at a pretty reasonable level. He did well locally and regionally and the state, and went to some national tournaments where he got decimated in the first round. And so he sort of started thinking a little bit about why it is that others continue to improve and he didn't. And he talks about Rafael Nadal, but because Grant Coombe is having a love affair with Roger Federer, I thought I would put Federer in here instead. But what he essentially noticed was the #1 ranked players in the world all have coaches. And these coaches are there to observe every practice, every game, every tournament, to give them feedback on simple mechanical things to help them improve their games. So these are the best in the world, and they still have coaches. And then he talks a little bit about the world of music. And he called Itzhak Perlman, who's a concert violinist, you might know. He's world-renowned, happens to have polio, don't know if you knew that, and so he's confined to a wheelchair. And he called Itzhak Perlman and said, said, my understanding is that the culture of music is such that once you are out on, and you've made it and you're a professional musician, that you rely on yourself to improve. Why don't you ever take more lessons? And he said, well, I do take lessons. I take lessons from my coach. And his coach is his wife, who's there beside him. And his wife is also a concert violinist, and she sits in the audience for every concert and is able to pick up things in his phrases and the way that he plays that he's not able to hear, and provide him feedback with that, and he's able to get better as a result of that. So what he did was he thought, why don't we have coaching in medicine? And so he did a little experiment, and he recruited a retired surgeon, was one of his former professors, and asked him to come in and watch him operate. So he's an endocrine surgeon, and so he was doing a thyroidectomy. He'd done thousands of thyroidectomies, and this surgeon watched him, and afterwards sat down and picked up on a number of subtle little things that he could have done differently that could have improved the efficiency of his operation. Things like the way the lighting was positioned and the way that the patient was draped, and where his assistant was standing, where he was standing and getting in the way of his assistant. And when he instituted these changes, he found that he was able to do these surgeries with much more effectiveness. He then had the surgeon kept coming in, but he relayed a story about a laparoscopic adrenalectomy that he performed. And he was a little bit reluctant to do it laparoscopically because it was a fairly big tumor, but he thought, I'll go ahead and do it anyway, laparoscopically. And sure enough, he got into trouble. He got some bleeding, and he had to convert it to an open laparotomy. And so after the procedure, he had his head hung down and his tail between his legs, and the surgeon said, yeah, you probably should have done it in an open way, but there were also things that you could have done that could have made it a safe operation laparoscopically in terms of finding your tissue planes and taking a little bit more time. So the coach was able to pick up on things that he would not have been able to see. So now that you know that coaching, and we'll talk a little bit more about that later, is one way that maybe we might think about things that we can be observing but get feedback on. What are the things that you think that you would like to have looked at if someone was going to comment on your performances? If I was going to watch you or try to get information to help you to improve yourself clinically, I'm not talking about academics, I'm talking about clinically, what are the types of things that you would like to have looked at, and in what way?
I want to know that I'm communicating with the patients properly in terms of where I'm going with investigations and the treatment discharge plan. So that they understand the care plan and it's able to carry it through.
So how would I be able to tell if you're communicating properly?
You may pick up, if there's someone standing behind me, you may pick up on cues or verbal cues or nonverbal cues that I'm missing, that the patient isn't receiving the information properly or that they are.
So someone directly observing you mean?
Potentially, yeah. Or somehow following up to see if the care plan was carried out.
Okay. John?
Like some kind of an indication of the appropriateness of my test ordering.
Mm-hmm.
One could certainly look at that in a very general way, just in terms of one's rate of ordering certain tests, and but that's a pretty gross measure in order to actually determine whether the tests were appropriate, or perhaps a test would have been appropriate that I didn't order. Probably requires a much more in-depth sort of chart review, and even then that's fraught with problems because it's all retrospective.
Right. Okay. So have someone take a look at your charts to try and think about your clinical decision making and whether or not you are appropriately ordering investigation?
Yeah, either inappropriately ordering unnecessary tests or inappropriately not ordering a test that should have.
Okay. Great.
So, I mean, after 25 years of doing this, I feel like I should have everything looked at. But I think what I'd like to have done is whatever someone was looking at, I'd like to have it compared to a baseline, to a gold standard.
Okay.
So let's say as a department of 60 plus physicians, if we had developed a standard for particular tests and how we order them, or a particular level of communication with patients, or particular therapies that we commonly institute, I'd like to have someone observe and see whether I'm meeting that standard. Do I exceed that standard? Am I below it? Am I right on the middle? And I'd like to have that done on a regular basis for various different standards that come up as they get established in the department.
Making judgments against a standard is very difficult because often the standard doesn't exist. Certainly in terms of therapeutic choices, there are guidelines that exist. Very often the standard is where you are compared to your peers in terms of different types of performance indicators that can be looked at. But that's a challenge. Rod?
I think one of the things that's at the heart of receiving feedback of any kind, though, is a permission to be either wrong or to be average, going back to the original slide, which I think is clearly absent from all medical education and dialogue, and there's no permissiveness for being either wrong or on the wrong side of par, and I think that overarching narrative is absent from medical education, which then makes us many people very uncomfortable because it's never been introduced by any leaders, clinical leaders, educators of theirs to say, you're going to miss some, and that's okay and that's expected. And so when you miss some, or if you get feedback saying you could have done your lighting a little bit better, knowing how to receive that and actually make changes with it is challenging.
So Atul Gawande invited someone to come and watch him, and so he was accepting of that and expecting of that feedback. And can you imagine, going back to the golf analogy, ever taking a golf lesson and have the golf instructor not say anything to you? I mean, that would be unacceptable. But what we need to do is to create a culture of acceptance of getting feedback on your performance. And just because someone is commenting on the way that you might be able to do something better doesn't mean you're a bad person. It just means that there are things that you need to improve upon, and that's the case for all of us. Derek? Yeah.
I guess going back to the golf analogy too, Bill, I mean, the problem is when you're getting that feedback, how do you know that it's correct? That's getting back to standards you talked about. I mean, sometimes I think, in this age of fiscal restraint, we've clearly got a system that's not tenable, and think, even when I think about, okay, like I had one lady one time, and she's a middle-aged lady with belly pain, and she was tender on the left lower side, and I really couldn't think of anything bad. She was kind of tender, but she looked so well, and as usual, I didn't really do anything. I said, listen, I don't think this is anything bad. It might be a little bit diverticulitis, but here's some antibiotics, things get worse, come on. She comes back like 8 or 9 days later, and somebody says, geez, I'm going to do blood work and all this CT and stuff, and it comes back with, infarcted fat on the bowel, on the mesentery, which is clinically significant. So is that a miss, or is that bad care? And similar to golf, you see golfers get screwed up all the time by the biggest teacher in the world comes in and tells them what to do, and it just totally makes a mess of things. So what's the standard, I guess? What's right and what's wrong in medicine? Clearly, I think you can do it for things like communication, because you can just rely on patient feedback. Did he communicate well? Did I feel better when I left? Did I feel like my questions were answered? But in terms of, even getting back to your case of this fellow from Brigham, did that really affect the outcomes, even though this other surgeon is telling him, you should stand here, you should light this way, you should hold the instruments this way?
We don't know. The reality is we don't know what the outcome is of direct observation and feedback. Has been well said. I'm going to take one more comment, and then I'm going to move on. Yeah.
I find as a resident, we don't really get a lot of direct observation, which I feel I would welcome it, because often, like with physical exams or our interviews, we kind of develop our own system, but we have no idea if we're doing things wrong or if we can improve on things. Right. In family medicine, we'd have days where we were videotaped, and then we would kind of review it, which was helpful. Or situations where I've had like VSAs and the staff is like, we're going to go in and you're going to do everything and tell the family, and then we're going to talk about it. So I find that feedback is helpful, because they actually saw us and know what we did wrong and have.
And I think that's an important point, because we sort of assume that in undergraduate medicine and in your postgraduate training that you get lots of feedback that includes direct observation. We probably know that that's not, you don't get as much as you should. But having said that, that's a lot more than what we get when we get out into practice. We never get any feedback. So the things that we're going to talk about is something called multi-source feedback, chart review and feedback, which gets a little bit about what John was talking about, looking at data, Greg brought that up earlier, and then direct observation with feedback. So I'm just going to look at each of these areas relatively briefly. I could talk about each of these specific things in a lot of detail, but I'm just going to touch on them just so you're aware that they're out there. In multi-source feedback, called MSF, also called 360-degree feedback, originated in the business world, and essentially what it is a survey tool where people are given surveys and asked to comment based on answering questions on your performance. The surveys are then analyzed, reviewed, and then sent back to the individual. And you can either just receive a package in the mail, that's the way it's done in some places, where you get a package and this is how you did, this is what you might want to consider. or it can be done in a facilitated way, which means that someone sits down with you and goes over your results and helps you to understand what they mean, not in a judgmental way. And it's been shown that the facilitated review of multi-source feedback is much more effective in helping people to commit to making change. And usually you're compared to peers as opposed to a standard. And the standard develops over time as more and more these surveys are done. So in medicine, multi-source feedback was pioneered in Alberta, and it's probably the world leader in multi-source feedback initiatives for physicians. It's called the PAR program, PAR, which stands for Physician Achievement Review, which was launched in 1999. And every physician in Alberta, every 5 years, has to go through this process. So they've looked at thousands and thousands of docs. And how it works is that you get a package of surveys, and there are 25 patient surveys, 8 colleague surveys, and 8 co-worker surveys that are not physicians. And you choose who you give them to, and you send them out. And so everyone's eyebrows always goes up at that. And you say, well, aren't you just going to pick your favorites? And the answer is, of course, you're just going to pick your favorites. But everyone picks their favorites, and so it all works out in the end. And what you see is, as I show you the graphs, everyone's scores are very, very high. But they're still able to discriminate to a certain extent who the people are that are doing extremely well and who are the people that perhaps need some work. So then this report goes back to the physician. And this is what you might get in your report. So I hope that the light blue projects okay. So in the surveys that your colleagues receive, they're asked to comment on 5 different areas: clinical competence, psychological management or psychosocial management of patients, their observation of your patient interaction, professional self-management, which includes their education, and consultation communication. For each of these attributes, there will be several questions that would have to be answered, and then the final score that you'll see in the second to last column on the right is essentially the aggregate of all those questions that are asked. And so the blue shading represents the range of scores that come back. The thick black bar is your score, and then the 2 hash marks are essentially 2 standard deviation scores, so that if you get above a hash mark, you get a commendation little squiggly or symbol, which is those sort of horizontal flags on the right. And if you get below, then you get another little symbol that says maybe it's something you should pay attention to. So these are the types of questions, for example, that a colleague might be asked. Within the range of services provided by this physician, he or she performs technical procedures skillfully on a range of 1 to 5. So these are the types of questions that are asked of the colleagues. And the numbers of surveys that are sent out, meaning 8 for colleagues and coworkers, has been validated. Patients are asked different things. So patients aren't asked to comment on your competence. Patients are asked to comment on things like your communication, your professionalism, even stuff for office-based practices like what your experience is like trying to make an appointment. So does the phone always go to voicemail, that sort of thing. And so patients are asked different things of colleagues, and docs are often concerned about this. Well, I don't want patients commenting on my competence. Remembering that competence is a big thing. It's not just what you know and how you make a diagnosis. Patients comment on your ability to communicate and the way you interact with them. So how effective is it? I'm going to say that it is moderately effective. And a lot of people wave the PAR flag, and a lot of jurisdictions are starting to use multi-source feedback. So Alberta uses it, Nova Scotia uses it, Manitoba has just started using it, Ontario is going to start to pilot it. So there will be thousands and thousands of physicians every year that go through this process. And it's been shown that it helps people to think about making change. It helps people to make changes in the way they communicate, maybe a little bit. It hasn't really been shown to change a lot of their practice behavior otherwise, and certainly hasn't looked at patient outcomes. Certainly the tools are reliable, so it's easy to get the same result if you use the same tools. So I think it's a part of a package that can be used to look at physician performance, but by no means is it the be-all and the end-all. And I think, unfortunately, in some jurisdictions, that's sort of considered that. So what about for eMERGE? There's one study looking at the use of PAR for emergency medicine. My thumbs down smiley there is only because the study really didn't look at much other than the tools. So it doesn't tell us anything about whether or not it changes docs' behavior in the emergency department. It just shows that the tools have face validity, they're easy to administer, and that they're somewhat acceptable as far as the eMERGE docs are concerned. Okay, chart review and feedback. So this is a process where someone systematically takes a look at your charts, to take a look at both your documentation, so whether you're writing your discharge instructions appropriately, and your care based on the history that you document, and the investigations that you order, and the disposition of your patient. There can be a general thing, so you can randomly check just 20 charts, or it can be a directed thing where you say, look, we're going to look at all charts of patients with asthma or COPD and see how you manage those. The CPSO, as some of you, has anyone been through a peer assessment from the college? Okay, two people. I know Drew has as well. So a peer assessment essentially is a chart review with feedback. And we've been doing this since 1980 is when the program first started. We use discipline-specific modules, so there's a different set of assessment tools that are used for emergency medicine as would be used for pathology, for example. Currently, we're revising the eMERGE modules to look at two different groups of things we're going to be looking at. One is presentations, and the other are diagnoses. So when an assessor goes in to look at your charts, what they will do is say, I want to have charts on patients with abdominal pain, chest pain, and shortness of breath. And I also want to have some charts on asthma, NSTEMI, and sepsis. So they will look at those two different types of things to provide feedback on your documentation and care. This is a brand new, never been seen before form that essentially is going to be a new module that we're going to start piloting, looking for emergency medicine. And this is the diagnosis of asthma. So we will look at a bunch of charts with asthma and look for some of these specific indicators. So did you document the medications that the patient is receiving? Did you talk about past history appropriately? And asking in a global way whether or not the chart contained those specific elements. It's a relatively efficient way of looking at things, and I can tell you that some studies done in the early 80s showed that if you document really well, then chances are you provide really good care as well. If you don't document well, that doesn't necessarily mean you don't provide good care, but the opposite is true. And these are just some stats from 2011 from the peer assessment program for all physicians in Ontario. You see that overall, 85% of docs are providing satisfactory documentation and care. We do it in a random way, so the only docs that we target is when you turn 70. You'll get assessed by the college every 5 years through a chart review like this. The Quebec College has a targeted approach, so that they have a number of indicators that they have developed that would put you at risk for having competence issues, and they only go after those docs that have got those risk indicators. Whereas we randomly select physicians because we sell it as an educational program to give you feedback on your documentation and care so you can improve on things. You'll see that docs who are 70 do significantly worse. 74% are satisfactory, whereas they're 85% overall. Okay, so what about data review and feedback? This is something that Greg referred to, and there's all sorts of data that we could potentially take a look at. It would take some work for us to do this. But we've got computerized systems that log times that we see people. Some of it would require chart reviews for sure, but there are a number of things we can look at. So we can look at just sort of process type things. So the number of patients you've seen, the types of patients you've seen, the number of patients you've seen in the last 2 hours of your shift, the time it takes for you to reassess patients, how often do you refer patients on, and all these things would be compared to your peers. And then some other more sort of outcome-related things like your return to emerge in less than 48 hours, the discrepancies on PACS, your use of investigations, online ordering will help us with that, use of return outpatient imaging, and then narcotic prescribing. Narcotic prescribing is an interesting one because as you know, when you write a prescription for narcotics, you have to put your CPSO number on it and a patient identifier. And so the Ministry of Health is collecting huge amounts of data that at the college we were given a glimpse of a few weeks ago on the prescribing patterns of all of us. So each physician has got a unique identifier, and they can go in and find out how much narcotic each individual is prescribing, what narcotics they're prescribing, in what quantities, and to what patients. It's really a powerful database that ultimately could be used for good or evil, I suppose, in that you could provide feedback to docs on what they're doing. If we had access to a database like that, or databases like that through our hospital-based system, we could easily provide feedback to ourselves on how we're doing compared to each other. So I wanted to come up with an example of that, and this is just something from our billing group, and it's maybe a simple example. The letters on the left are anonymized physician identifiers, and these are just the billing codes that we do. And so you see that physician AC, whoever they are, if they're here, I'm sorry about that. You see that in 2010, they billed 3.1% of their billings were in resuscitation codes, which was down 0.3% from the year before. But if you look at the comprehensive codes, which is just another type of billing code, they actually went up by 8%. And that light green shading means that they were in the top quartile in terms of that. So getting some feedback like this to look at how you're doing compared to your peers can be a powerful motivator for change, because most docs are a bit competitive and want to improve what they're doing so that they don't disappoint. Certainly this is a billing example, but similar types of charts or graphs could be presented for other types of outcome indicators that we just talked about. Direct observation and feedback. I mentioned earlier that there's opportunity in this area because there's really not much out there in terms of studies on the effect of direct observation and feedback. I did a PubMed search just in the last 5 years, and there was one study, and that was really a review article that was looking at physician assessment overall and mentioned direct observation and feedback, and they basically said that there was no evidence that direct observation changes anything. And I would submit, I think that's just because it hasn't been well studied. Certainly coming back to Atul Gawande, he said this in his essay: "In the past years, I've thought nothing of asking my hospitals to spend hundreds of thousands of dollars to upgrade the surgical equipment that I use, in the vague hope that giving me finer precision or reducing complications. But the 3 or 4 hours I've spent with my coach each month have almost certainly added more to my capabilities than any of this." Anecdotal, yes. Something to pay attention to? Yes, I think so. So what's being done now? We talked about the CPSO, and I want to talk a little bit about CAHO, and then we'll get Dr. Cheng to come up and share his experiences. CAHO is something I'd never heard of before I started working for the college, and it's the Council of Academic Hospitals of Ontario. So it's basically all the teaching hospitals who have an organization that advocates for common interests in that group. And they started discussions in 2007 on something that's now called the Physician Quality Improvement Initiative, or PQII. And the goal is to enhance physician self-awareness, provide opportunity for development, and measure progress against goals for individual physicians. There are going to be 3 elements to this, the way that it's rolling out now. And the hope is that this program, or a program like this, will roll out to all of the academic hospitals in Ontario, and that every physician who's working at an academic hospital in Ontario will undergo some sort of a physician performance process such as this. So they're looking at 3 elements: the PAR, which is the multi-source feedback, mostly because it's available and it's easy to use. Second, a joint process with the chief, and that basically means you sit down with the chief or a designate of the chief to review your results of that multi-source feedback, plus other hospital-driven information such as your complaints and your academic performance. And then something called the Physician Quality Improvement Cycle, which really is just indicating the fact that this is an ongoing process, so that you will go through this process and hopefully improve and then have it looked at again on a systematic and regular basis. So they've started. They're doing it in 2 phases. First phase is a pilot where 3 hospitals have already signed up and started distributing the multi-source feedback forms. That's UHN in Toronto, North York, and Hamilton Health Sciences. They started giving the surveys to the docs to distribute in the spring of this year. And I want to say that the numbers are small. So far there's probably been 20 or 30 docs in total that have had surveys go out on their behalf. They will be analyzing this pilot, and then after that they're looking for broad implementation throughout all of the academic hospital systems. So that's something that we can look forward to, but there are things that are already going on in London. And so I asked Dr. Cheng to come and tell us a little bit about what's going on in the Department of Anesthesiology and Perioperative Medicine in physician performance review, and then we can, I'll just finish up after that, and then we can take some questions and have some comments. I'm supposed to give you the microphone, I think, so that they can hear you on the recording.
Okay, thank you very much, Bill, and thank you and good morning to all. And I appreciate the opportunity to come and share some of our experience with you from our department. As Bill indicated, this is indeed very timely for all of us as a physician in the current stage of the performance and the accountability framework, pushing both in North America, continents-wise. As you know, that the P4P in the US has been talked about payment for performance. So what is performance is very important for us to really get a handle of before someone else put it on our table. As actually one of my former faculty in my department, Sao as a before said, if you're not at the dinner table, you may turn out to be on the menu. So we do want to ensure that we define what we want to assess our own performance. Many similarity between your department and mine. We have very technical and cognitive skill set. So there's two components as what we're moving into is what is your cognitive aspect for your medical skill set in assessing, treating patient, and also the technical skill set compared to the surgeon and in contrast to internal medicine. So in London, as KO, as Bill has indicated, Gary actually is in the loop as well. Most of us who are chair chief has been gone through the beta test about 7 or 8 years ago with the CDP, which is a continuous or career development process. And what it does is talk about the clinical aspect. You fill in your self-assessment of your clinical aspect and your teaching and the research, and then a short-term plan and a long-term plan regarding a self-assessment feedback, not unlike what you saw in those multi-feedback, and then a vast feedback from your co-worker. So they send out to your peers. In our situation, anesthesia, the nurses, the surgeons, and also the PACU and the out of OR session. So we have all those collected. I have 80 faculty. In the last decade or so, it's very difficult to put a handle if you talk about competency. That's why one of the aspects we really need to get a handle ourselves in any of our clinical department is to ensure that we define the performance. It's not just competency per se. You talk about professionalism, code of conduct. Indeed, I have only 2 faculty that I have to deal with and put on the CPSO assessment and put on the reduced scope of practice. So in our situation, we need to ensure the safety and the quality. So you have to define quantity of measurement of performance, how much you full put, how many patients you see, what is your needle to, the patient hit the door to the needle time versus us, is the start time for anesthetic, what is the turnover time, et cetera, et cetera. So those are only quantity of care, not so much of a quality. If we really go into the quality of assessment, in anesthesia, we do have tap into the hospital, which we actually volunteer ourselves and have access to the data with the hospital, and I print out from the hospital quarterly. So I know exactly how many of my faculty, who are the faculty who always start late in the cases. So after 3 straight, they will have a conversation with me after they spoke to the site chief. So by doing so, we try to qualify some of the quality of care that they are providing. Not so much they are unsafe, but their behavior might impact on the safety of the patient and impact on the patient care and outcome. And we do have all the administrative database from the PACU, nausea and vomiting, hypotension, reintubation rate, arrest, et cetera, And also I have every single faculty in doing cardiac anesthesia, their transfusion rate. So we have all the blood transfusion in each cardiac surgeon and each of our anesthesiologists. Obviously, you have to match up with the case mix so that the acuity match with each other. But give you a trend, who are the big transfuser or the threshold of transfusion is low. So by doing so, it's not that they are safe or unsafe, but you need a conversation with those. So by doing so, we continue to refine our care. So data is very important. Data is vital, but as everybody say, garbage in and garbage out. So you need to define your own quality, both for quantity and quality, and drill down to those. Partner with the hospital, get your own data, review in your program, and so that you'll be able to continue improving. Ultimately, is the patient center and patient benefit. So we've been going down that path. So 80 of us in the faculty every year. We started now to have a CDP, have this feedback, and look at a quantitative and also some qualitative. The bottom line for unsafe is usually come from complaint letters, unfortunately. By the time the letter reached my office, which means there must be about 10 of those unwritten ones out there, incident being occur. So by doing so, I often need to sit down with the site chief and the respective faculty, get their feedback, and then continue just to monitor those people and make sure that they comply regarding the safety of the patient. If needed, then the CPSO need to call in and do assessment. So that's some of our experience. As I mentioned, it's important for all of us. We are very similar. We need our technical aspect and need our cognitive aspect. So I wish you all good luck and tap into the resource of the hospital, because without the right database, you cannot reflect on your own practice. Thank you.
Thank you. And so I've just got a few questions left that I think that we should think about and maybe talk about in the time that we have remaining. And the question is, and you know, I've sort of planted the questions in hope that I'm going to get some of the answers that I want, but do we want this? I mean, do we want to have this? Because it's that old phrase, careful what you wish for. Do we really want this? We want all this information about us being fed back to ourselves. And if we do want it, what do we want? And I'm glad Shelley's here, because I think that we can provide opportunity for our research agenda within our division if we are interested in moving forward with something like this, because it's not been well studied. I think looking at outcomes of physicians' performance based on physician performance feedback review systems would be a great thing for our division to focus on as a research agenda, because I think we've got the right people to do it, and I think we've got the opportunity to do it as well. We're small enough that we can succeed in this as well. Can we develop a coaching model? Is that possible? Do you think that we can develop a model where we're actually help each other from direct observation to improve ourselves? And finally, are we willing to support it? And by support it means we all have to be engaged. We all have to be willing to be involved. We probably have to support it financially to a certain extent. We certainly have to support it through manpower. More than anything, we have to support it through wanting it to happen, I think. So here's my dream system. And it's no mistake that these are the 4 things that I talked about. I don't think that any one of these types of feedback mechanisms is enough to provide me with information on what I do and how well I do it. So multi-source feedback can tell me a little bit about how I communicate. Data review can't. Chart review can tell me a little bit about my clinical reasoning process, if I'm able to justify what I'm doing. And then a collaborative coaching model can provide me with all sorts of different things, I think. So this is what I would like to see. And I guess my question is, well, what would you like to see? I think that we've got the people to do this. I think that I could work with any of you people in terms of getting feedback and giving feedback. And I would like to get your feedback on what you think we should do about this. Should we move forward, and should we try and, from a grassroots level, develop a system that we can all use and that's all going to be helpful to us? It's coming anyway, right? Something is coming. What's coming, I feel, is inadequate. I think we can develop something that's a little bit more robust. So I'll stop talking there and ask people for feedback.
Bill, just one added aspect. In the Royal College too, the competency and assessment is coming back in anesthesia, the simulation, and the simulator is a big push, especially the case scenario and management for crisis, and the technical skill set that we can learn and retool for competency. So the Royal College actually actively looking at that too for simulation setup.
And to that end, the Royal College, the Council of the Royal College recently approved the requirement for physicians to be engaged in some form of assessment for their maintenance of certification program. So if you're Royal College certified, it'll be an expectation in your next cycle that you engage in some sort of assessment. Now, they're using the term assessment in a broad way, so it might mean just a self-assessment and reflection on what you're doing, but it could mean something like this. I will point out that a robust system of assessment gives you huge points in either the Royal College or the CFPC's education plan. Adam?
Bill, thank you very much for taking the time to put this presentation together. It really hits home with me, and I think it probably hits home with a lot of the staff members as well as residents. because currently we exist in a bit of a feedback vacuum, as was pointed out by a number of people. And I completely agree, this is somewhere we could go as a pillar of emergency medicine, in London. And you asked about support. I personally believe that we should pay at least a reasonable portion of our clinical dollars should go to this type of a system, and our pay at the end of the year should be based on how you chalk up to a system once developed and agreed upon by the group, similar to what Grand Innis has done in Calgary. But my question is actually more for Dr. Cheng. You mentioned a number of data points, but seemingly simple, like reintubation rates and transfusions and all that sort of stuff. I get the sense that we could generate similar type of quality data, but we need to work a lot with the computer systems that exist within the hospital to generate that data. And I'm wondering if when you were setting that up, or if your colleagues were setting that up, was that something that you did a lot of legwork on, or did you have administrative support to do that, and how that kind of bore out over the initial stages?
It's a very important point, because the health informatics and the electronic health record is actively diffused into the system in the hospital too. So make use of that opportunity. So when we were engaged in the Hugo, I have my faculty actually put into the quality council with the hospital. So we have anesthesia actually put in some of our requirements. So when they set up the domain, some of the key outcome for patient that relate to anesthesia care can be tapped into. Hospital get all kind of outcome, critical incidents, et cetera, so they have many outcome. But I would want to really look forward down the path. Ultimately, is a patient outcome. We can do a lot of soft indicator or metrics for our care, but at the bottom end, a lot of our art of medicine, to a certain degree, there's several ways to do a procedure or several ways to make a diagnosis and treat a patient. Ultimately, is the cumulative outcome of the patient, either be morbidity or mortality. If the patient has a stroke, in our case, in cardiac surgery, if recurrently on the same anesthesiologist and different surgeon that the stroke rate is high, then will be a signal for us to look into it and say, is the perfusion pressure be a problem during the pump run whenever that person is monitoring the patient, et cetera, so give you some direction, but bottom line is the outcome. So you need a hospital database. When you go to the rare incidents, you need a bigger database to reflect on the validity of the metrics.
I think the reality is that the first step is to, as a group, is to pick what the indicators are. What are the quality indicators that you want to look at, and then maybe go for the low-hanging fruit and find out which are the indicators that you can relatively easily access.
The idea of how much support a hospital put into. I'll pick an example. Let's say we wanted to know return visits within a week, and we would need, in my way of thinking this from health informatics, to be able to data mine the Cerner system in order to do that, and need the correct physician in that. And I don't see that as something that we should have a physician working on, that should be the ER administrators or the health informatics. And so is that the kind of support you were saying?
They will give it to you, because you talk to Gary, they will push the administration. This is exactly the hospital want to know, because this is part of their quality data too. The patient discharge and bounce back to readmission. These are the data that they need to reflect on themselves too.
Adam, just a comment to the response to you. We can get that particular data. One of the difficulties we have in our data collection is that, unlike, say, anesthesia, where, it's Dr. Davey Cheng who's in room 1 that particular day, so all of the informatics that are collected from room 1 are attributed to him. Given our current registration system, the way we do, it makes it somewhat complicated to tell, because we don't mine back to the physician of record, right? So I can pull data, I can get data about how many patients we return within 24 hours, 48 hours, and then you need somebody to go back and data extract from those charts to see whether it was me, you, or somebody else who saw the patient in subsequent roles, and whether it was an adverse outcome. So, and I'm not sure, I haven't asked informatics whether they can in some way do that, highlight that in retrospect.
Yeah, I would argue that it's not acceptable that we continue along with that system, and that system needs to change to work for us so we can have performance improvement. And the idea that the physician of record isn't correct in health records, I think we should probably start forgetting about, because just the study that I'm doing right now, 92% of the time, when once it goes through the discharge database process and health records, so the 3-month process or whatever, it's right.
Okay.
it is the actual physician's right. So if it's right 92% of the time, then we should be willing to look at that and go with it.
And part of what I was referring to in terms of supporting a system like this means that we have to sign up for patients appropriately. We need to log on to PACS and when we're putting our own interpretations on so that we know that we're owning that data. Trevor, you've been waiting patiently.
I think I just want to say that physician assessment is great. I think we should be going there, although it's only one part of a larger system, and that's continuing education of physicians. And I think our system overall is poor for continuing education. And you can't initiate assessment unless you offer solutions or more education. And you can't just say to a doc, well, your assessments show that you're falling behind in these areas, so go forth and improve yourself. You need to offer the solutions too.
Yeah, couldn't agree more. They're innately tied to each other, but it's pretty difficult to have the education until you know what needs to be learned.
Again, comment on that is very true, as I mentioned, in our profession for technical skill sets especially. And you do need to have a safe environment for the practicing clinician to retool themselves and re-educate in some of those aspects, especially the evolving technology and procedure coming out. In this center, we have huge amount of cutting-edge research and like minimally invasive surgery. So I have to continuing promoting and shepherd my specialty group into the cutting-edge anesthesia and surgery to complement those, i.e. even now Rob doing the TTE and the echo, all of those. Our faculty actually will not be comfortable. Actually, the resident is much better than them doing a block with an ultrasound pro than the faculty, so it's difficult for them to teach. So we need to make sure that there's a safe environment for the faculty to retool themselves, not feeling that they're inferior than the resident now, that they don't want to continue skill set themselves. So it's a bi-directional. So the department have to step forward and say, we're going to set up some safe environment for our faculty who feel short on some of their skill set to be retooled with a session for them only so that they can retool those without feeling embarrassed or not able to teach the residents.
And the other thing is, Trevor, I'll just highlight that my experience at the college is such that when an external body comes in and assesses a doc and says, you need to do this, there's understandably some resistance to that. So no one likes being told. But if this is a system that we develop collaboratively and we can be engaged with, then I think that there's probably more likelihood that people want to also be engaged with that second step, which is sort of making those changes that are necessary. John?
I just had one comment. It's just, I think, when people say that there's a lack of feedback in the system, you sometimes own that yourself if you don't ask for it too. So, I got some feedback 2 nights ago just because I asked the charge nurse, how am I doing on throughput? How would you compare me to, say the best guys in the department? And so she was able to give me that feedback. But you have to, you had to ask her, and she was one that I would, accept her recommendations as being, not just saying, oh yeah, you do fine, She's one that I would take to heart. So I think, people need to ask people and, sort of reflect internally, how am I doing, and ask the stakeholders. So, am I keeping up with what I should be doing? Am I doing okay here or not? So, I don't think people need to sort of look at your practice and come and say, well, you're doing okay, you aren't doing okay. I think, you need to go out and seek some of that back on your own.
I just wanted to emphasize how valuable the one-on-one observational experiences. We talked about the surgeon who had a retired colleague come in and give him some pointers after the surgery was over. Several months ago, Tarek and I did this over, about a 4-hour period, and we took turns assessing patients. So we were not on duty, we were just picking up patients and then going to see, and one of us was watching, and then the other was, kind of taking notes, the other was caring for the patient. And I think the value of that was, we both got tremendous value out of that. I saw things that Tarek did that I don't typically do. He saw things that I do that he doesn't typically do, and we both learned a lot from one another. So it wasn't threatening. It was, oh, I didn't realize I did that, or I'm glad you picked up on this particular thing that I did because I got into a confrontation with that patient, and, you know, so we talked about how one might have avoided that and so on and so forth. So it can be a very valuable, very rewarding kind of experience to actually follow one around like that. And it was both ways. It wasn't just one of us saying, you know, you suck, or, you know, you should have done this, you should have done that. It wasn't teacher, learner. It was both of us were teachers, both of us were learners.
Great. And I'll just maybe finish off by saying I think that a system like that, and like all the things I'm talking about, is also a way to help a group that's pretty big and getting bigger to gel and work together towards a common desired outcome, which is improving our own practice. So I think I'll stop there. I'm not sure where we're going to go from here. I think I'll probably speak to a few people about whether or not we take some steps further in terms of actually putting a pen to paper and coming up with a proposal to develop a system for our group. If you're interested, let me know, and we'll see what we can do. So I want to thank you for your interest in this topic. It's a little unusual, and thank you for coming.